Okay, good morning, ma'am. Thank you for the opportunity. Today, we want to present about our discussion group. Our group consists of me, Johannes Gilbert Dua Padang.
And me, Anselmus Ensley.
Okay, next. Okay, first, let me explain about our introduction case. First point, the patient suffer from a severe stroke. Especially a brain hemorrhage. This means there is bleeding inside the brain, which can damage brain cells and disrupt important body functions such as movement, speech, and consequences. Because of its severity, this condition requires immediate and careful medical treatment. The patient has already been treated in the surgery department. This indicates that medical intervention, possibly including surgery, has been performed to control the bleeding and stabilize the patient condition. This step is critical to prevent further damage and improve the chances of survival. Okay, next. The patient's current condition is stable, but still has partial paralysis. Stable here means that the stable here means that the vital signs are under control, but the presence of partial paralysis shows that patient has patient has not fully recovered. It also indicates that there is still neurological impairment that needs continuous monitoring and treatment. Last, the ICU is equipped with advanced medical technology and specialized healthcare professionals who can provide continuous monitoring and immediate response if the patient's condition changes. This transfer is an important step to ensure the patient receives that highest level of care during recovery. Okay, why handover is critical? This situation is time sensitive because the brain is highly dependent on oxygen. When oxygen supply is disrupted, brain cells can start to die within minutes. This means that any delay or mistake during handover can directly impact the patient condition. So, speed and accuracy are absolutely essential. Next, the, the patient is connected to multiple medical devices such as a ventilator, IV lines, and monitoring equipment. These devices are not just supporting the patient, they are sustaining life. During the handover, all equipment must continue working properly without interruption. Even a small error, like a disconnect line or incorrect setting, can create serious implication. Next, the process involves multi-team coordination. This is not handled by just one person, but by several teams such as the surgery team and the ICU team. Each team member has a specific role and they must work together seamlessly. Clear and structured communication is crucial to ensure all important. So, handover is critical because it combines the time pressure, technical complexity, and teamwork. A well-executed handover can save a life, while a poor one can lead to serious consequences. Okay, next. Between F1 pit stop and hospital handover. First is background identification, like we know the car condition like full tire wear, damage data, and in the hospital handover we see patient identify, diagnosis, and surgical history must be verified before transfer. There are situations in the Ferrari pit stop like high speed environment, rise of mechanical error, and time pressure in the hospital handover, like risk of patient equipment disconnection, miscommunication. One is recommendation. In the Ferrari pit stop, we immediate decision like change tires, adjust strategy. In the hospital handover, we see the clinical recommendation like monitoring, medicine, medicine for their treatment and for their treatment plan.
Problem in handover in the hospital and the Ferrari pit stop. So the handover in hospital is chaotic communication, no clear sequence, multiple conversation, and role overlap. But in the Ferrari pit stop, there is strict role assignment, like the wheel gunman or the who checking the car. After that, there is silent execution. There is no like people talking. There is one job, one man. After that, error tracking system. After we talk about the difference, we talk about the handover procedure at the hospital. The first one is identify the patient, the before transfer. There is patient ID and diagnosis verified. The second one is vital sign and medication updated. So there is no communication error after we give the vital sign and medication to the ICU. The third one is neurological status and communicated. Because the patient is getting surgery because of hemorrhagic cancer, there is a neurological status that being communicated by the surgery team to the ICU. The second one, there is handover during the transfer. So the assigned nurse in charge, continuous monitoring. There is continuous monitoring like the half paralysis of the body that we used to monitor because of if there is no significant change, we should check the surgery that we do. After that, there is real-time verbal update, like uh, we can ask the patient how they feel because in stroke there is many symptoms that can be detected in the verbal update. The third one is after arrival or in the ICU. There is SBAR handover. So the SBAR handover is so important that I will explain it later. After that, there is double confirmation and full documentation. Double confirmation is like we should check all of our patient ID, vital sign, neurological status from before transfer, during transfer, or after the transfer. So there is no error and full documentation. The example of the SBAR. The example of the SBAR, the first one is situation. The S is situation. Mr. A, a 65 years old patient, is being transferred to the surgery department to the ICU following surgical procedure for hemorrhagic cancer. His condition is currently stable. The second one is the background. So SB, B is the background. In the example is the patient was admitted due to a severe hemorrhagic stroke that result in intracranial bleeding. A surgery intervention has been successfully performed to control the bleeding, with no intraoperative complication reported. The third one is A, assessment. The patient is conscious but present with paralysis on the left side. The body vital signs are within stable range. Blood pressure is well managed and there are no indication of ongoing bleeding. However, the continuous neurological observation is required. The fourth one is recommendation. It is recommended to proceed with the intensive monitoring in the ICU, including the routine neurological evaluation and strict blood pressure management. Additionally, early planning for rehabilitation should be considered. So the SBAR is like the checklist or the paragraph for how surgery team want to do with the patient in the ICU. So they give the SBAR to the ICU nurse. So the last is key insight and the conclusion. The key insight, the first one is most of our failure are caused by system, not individual mistake. There is like miscommunication, etc. The second one is lack of structure leads to information loss and delays. We can use SBAR for the better communication. The third one is very pit stop succeed due to a clear role allocation, fixed sequence, and communication. There is just one tool, one man, and there is no communication, so there is no mistake, chance for mistake. The conclusion is ICU handover must be structured, fast, and error controlled. Applying Ferrari principle can reduce miscommunication, improve patient safety, and increase efficiency. There's the explanation from our discussion. Thank you.